Hello, fellow zebra hunters. This is Diagnostic Atypia. Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant, with key identifying details changed.
I'll just let the listeners know that Mike and I just debriefed on our loan statuses. And listeners, we're plugging away at our loan still. We're PGY almost sixes now, Mike, right?
Yeah, I think
Sixes?
so. I think so.
Listeners, if you want to help us with their loans, we actually don't even have a donation bin. We'll find something maybe to help us with this.
As
One
if our
day,
listeners don't also have loans.
You're right, Mike. You're right. Okay, but we could give them some education today. So
Yes,
this
we
is
can do that. Not financial planning, but we can do the medical
definitely not.
education.
Yeah, no financial planning on this podcast. Definitely not. The least qualified person for that. All right, so this is our first rapid response case. It'll likely become a new episode subtype on the show. The idea is self-explanatory. Instead of going through a case spanning many weeks or months with an unexplained diagnosis, the focus of the rapid response is going to basically going through an encapsulated case occurring during a patient's hospital stay. And today's rapid is a case of dark stools. It'll be 3 aliquots occurring over the course of several hours. So let's get started. This is a case of a patient in his 80s and had recently been in the hospital just a few short months ago for a right-sided ACA stroke, for which he was discharged on dual antiplatelet therapy. He was thereafter living in a rehab and came into the hospital this admission for hematemesis. On his arrival, he was in hemorrhagic shock, so after stabilization, underwent emergent EGD, found to have substantial peptic ulcer disease with ulcers in the esophagus, in setting of grade D esophagitis, several small gastric erosions without active bleeding, and 3 large duodenal erosions, one with a pigmented spot suggesting recent bleeding. And I'll put all of these scope images actually on the website, Mike, and just share briefly the first scope photos. Um, so here is the esophagitis photo, and stop sharing that. And then here is an ulcer,
hmm
nice and juicy. No visible vessel. Um, so after transfer to the floor, a few days later, he had repeat melena with an associated drop in hemoglobin to 7 from 8.2 over the course of 24 hours, for which he underwent a repeat scope showing basically the same findings as before. And around this time, H. pylori testing from the first EGD came back positive. GI said they think the duodenal ulcers were the likely source of the recurrent melena and recommended starting him on quadruple therapy for H. pylori, including bismuth. And given his stability after the second scope and need for Plavix for his stroke, Plavix was then restarted. Came on to service for this patient about 72 hours later. And when I came on, he had delirium and critical illness related dysphagia. So the first thing you're working on is kind of figuring out his nutrition plan. SLP comes by, clears him, so you go pull out his tube. And surprisingly, when you go meet him, he's oriented to self, hospital, and location, albeit his memory of events this hospitalization is very poor. But he's answering questions mostly appropriately and linearly. And on day 2 of service with him, his exam is largely unchanged. Some of his poor memory and confusion comes out when you ask him questions, and he's asking things like, on whose expense is this hospitalization? And how do I get my events in order? And because he's had normal vital signs the days leading up to you coming on service, his CBCs are now being trended daily. So over your first 3 days with him, this is his morning hemoglobin trend: 7.8, 7.7, 7.8. On day 2, you actually were ready to discharge him in the spirit of getting him to rehab quicker. But since you're waiting on insurance authorization, he remains here. And then my questions for you come on day 3. And again, these are the same 3 days of that hemoglobin trend I just gave you. So morning of day three, you go and see him, and he overall is much more tired than the prior 2 days. His eyes are closed, and he doesn't try to shake your hand like days prior. He has much less verbal output. You do get him to open his eyes, and he does follow commands. He does like normal finger nose testing for you. And we ask him why he's feeling tired. He says it's, quote, from a variety of ailments. He doesn't say too much else. About 30 minutes after you see him, the RN sends you a message. Quote, hey, he just had a large BM, looks very dark with some maroon clots, end quote. Question one for you is, how would you describe this photo I'm pulling up for you? And then question two would be what you would be doing next for him. Here is the photo, which I'll leave up for you.
Okay, I'm just gonna maximize this. So, I mean, the stool is definitely dark. Um, and I do see sort of like these, clumps here that look, I could see, it's calling them clots. I mean, I think that the general impression would be like this is probably melena until proven otherwise. It's, sort of you can see some stranding onto the cloth here, which, oftentimes it's sticky. I can't get any of that information, smell, stickiness. I'm just looking at a picture. But um, I will say that it's not quite as thick as I would expect in the areas where there's not clots for something like melena, but like I feel like I can kind of see through to the cloth underneath, whereas melena I think of as like gelatinous and dark and like completely opaque. So I'd say that there's some things that are not suggestive of melena here, but in his with his history, I think that that would be melena until proven otherwise. And there's clots too, right? I think there's clots. Now the issue, of course, is that this is someone who we know had an upper GI bleed and bled again, most likely. Has a very good explanation for that GI bleed, upper GI bleed, right? Peptic ulcers, esophagitis, duodenal ulcers, H. pylori positive. And so first on the differential is just that this is still stuff that is making its way through the GI system. This is not, we see this all the time where someone has had upper GI bleed and then, the GI fellow gets a text the next morning and it's, like, well, give it some more time. The hemoglobin is stable, so that's suggestive. And I guess, Andrew, the vitals are okay.
Yeah, coming up next.
Okay, all right. I'll wait for that. But you'd want to make sure that they're not in hemorrhagic shock, right? Those things would all make your pretest probability for just bleed in general would increase, and thus it would increase your concern for this. Um, Hard to ignore that he's on bismuth therapy now, right? So that's going to make your stools darker all the time, pretty much. And when I think about, sort of like fake news melena, which I think is on the differential here, I do see, it's a little weird. It doesn't quite, right? It's not quite as opaque as I'd expect. Um, PO iron, right? Activated charcoal, diet, like usually in like large quantities. So like a lot of blueberries, a lot of dark leafy greens, a lot of chocolate, a lot of grape juice, like things that just in excess start to make the stool look dark. Um, and then anything above, right? So like, they have a nosebleed or you irritated something in the oropharynx with the NG tube. Those things, not necessarily in the GI system, but kind of above the larynx. Swallowed blood, basically, will eventually make its way down. And then, of course, something bleeding in the colon or the small bowel, beyond the duodenum can always, of course, cause, melena rather than hematochezia. It's not less likely, but sometimes in the elderly, people with, bad colonic dysmotility, opioids, chronic constipation, sometimes they'll develop melena just because it's been sitting around for so long. But I think for him, I want to know the vitals next. It sounds like there is some clinical change in the setting of mental status, but is that just waxing and waning? Hypoactive delirium? It's possible, although it sounds like the day before we were feeling pretty good about discharge. So it's a little different. The thing that I can't get through this picture, and also I'll rely on you because I can't get it any other way, is like, is it does it smell like melena? I just can't say how much that actually. I mean, it really is helpful. I think. And again, the consistency. There's just kind of something here that maybe doesn't look quite right. And then the meds, which we already talked about. So I guess I would want to know, are there any other meds that have been started? Um, and yeah, let me know I guess let me know those
Yeah.
things. And
Yeah, I love it.
it's hard to justify a third endoscopy, which is probably going to demonstrate the same things. And I mean, what would change is if something was actively bleeding again, right? Like, and they had to do an intervention, clipping it, burning it, something like that. That would change management. But I'm not inclined to do that right away. Let me know your thought. Yeah, let me
Yeah,
know.
yeah. A lot of similar thoughts on my end. And you'll see in a sec, GI also had a lot of similar thoughts too. So you go and see him, and he looks the same as like when you saw him earlier in the morning, like very tired still. His vitals are technically stable. His heart rates are 50 to 60s range. Blood pressures are 130 to 160s systolics, and these are, you like go back and confirm, stable compared to prior, and temp and sat are normal. Families at bedside now and asking for an update on the overall plan. And you tell them that given the large BM and history of recurrent bleeds, you're going to go ahead and rescind that medical readiness for discharge that you had put in place yesterday and monitor him another 24 hours. And their only comment is he may look a little paler compared to the day prior. And given his recurrent bleeds, you do message GI, and they say basically like, hey, like we said after our last scope, we do expect him to pass clots for the near future given his recent bleeds, which we think are from the duodenum. So with that in mind, you go back to your desk, you sign your progress note, and continue the plan of monitoring another 24 hours with a CBC in the morning since everything is stable. Then, no more than 2 hours later, the RN messages you again, saying, "Hey, just got him back in bed from chair. He had another large BM, dark red plus clots. They recycle a blood pressure, and the systolic BP is 102 from prior nadir in the 130s." And I'll stop there. And oh, also, I did want to answer your question, some of the additional questions you had, because you're very wise to like look elsewhere, like no nosebleed, he's not like coughing blood, nothing like that. My sniffer is not as well trained as yours, Mike. I thought it just smelled like poop when I went to the bedside, um, and I don't think you wanted anything else, so I'll stop there.
Did it look like dark and tarry to you, or was there like, I guess when you looked at it, were you like slam dunk, this is Melina, or did you also, I mean, again, I'm getting like from like a picture, so I don't know if I'm just,
Yeah, yeah. I'm gonna give you one more photo in the next aliquot because there's like
okay.
another. Yeah, yeah.
I'll wait. Yeah. Um, so I mean, he now has a blood pressure change, which I think is what's significant. And there's maybe some redness to it now, which I'm hearing, which of course is different, and actually suggests that maybe there is some new element here because we're going to expect melena, we're going to expect clots, but we're not going to expect that consistency to change towards blood. It should kind of change away from blood. Um, so I don't know. I think that a repeat CBC, I think, is going to be helpful in the next hour or two. Not because I think if it's the same, I don't necessarily know it helps you, right? Because you can bleed and your CBC can lag. But certainly if it was 6.5 now, that would be helpful. So it's going to be helpful if it's abnormally worse. I don't know. I would put stock in it if it's the same. You have to kind of say that to yourself before you order the test, right? How you're going to think about what you get. And I was going to say orthostatics, but he's clearly already showing us that he's dropping his blood pressure, and it sounds like it happened after sort of quote exercise. He was moving around. So I think I am inclined to talk to GI again, and sort of push them on rescoping. What are they going to find? I'm not sure. I'm guessing that the thing we're worried about would be not necessarily some new pathology, but just sequelae of the known pathology. I mean, the other thing we did restart Plavix again, and quadruple therapy doesn't work that fast. That being said, I don't think it's like necessarily a new lesion. I think it's just these are high risk lesions and they bled because he's on DAPT. So I don't know. Those are my thoughts. I don't know if we have like a
Yeah.
BUN, if that's risen over the last day or two,
Yeah.
that could be helpful as well. And then I guess another question I have is just this is mental status, not necessarily this specific problem. Do we know if he has any liver disease that could explain like, you know,
Yeah,
just
no
people with
known.
cirrhosis that then have
Yeah,
blood
no known liver
Okay.
disease, no thrombocytopenia, nothing like that.
Yeah. The other thing I guess I'll just to not anchor too much here, like, do we have any systemic symptoms? Do we have any concern that this is like lower GI bleed? Like this is hematochezia, right? That would be the other kind of concern. So like, is there abdominal tenderness in the lower area? Anything to suggest, is there like diarrhea or anything to suggest that there's like dysentery, right? Like he just has an infectious colitis. Also, he came in with hemorrhagic shock. So does he have some sort of ischemic colitis? Just thinking about hematochezia, right? Causes of that as well, so that we're not anchoring on upper. But again, it's harder to just base rate here. I think we just had this. And I'm just trying to think if there's anything else I may not be thinking about because I'm anchoring too much. But
I no,
I think
that's
those are my
incredible.
thoughts. Those are my thoughts. Maybe if we think this is hematochezia, maybe you offer a colonoscopy. That would be different, but certainly not where his systolic's down 30 points. Yeah.
Yeah, I'll give you that photo to kind of help you make the upper versus lower decision in a second. No, you took that like three steps ahead of how far I got when I was solving this case in real life. I'm amazed. So you go and see him and take the following photo. Let me find the screen share button again. I've been telling Mike all week, folks, that I'm going to be showing him pictures of poop this presentation, so I deliver.
It's true. It was not entirely blinded now. I did know that I knew poop was coming. Um, yeah,
And
I mean,
and
I think
I'll
that this is, oh, go ahead.
yeah, I'll give you a little bit more info now, Mike, and you can kind of like
Sure.
put it all together. Yeah, so he looks the same, but given this picture is definitely more concerning, like you were saying, with like the systolic blood pressure drop compared to before. You asked the RN to start cycling the BPs more frequently now and get back in touch with GI just like you wanted with more urgency this time. No update from them yet, but an hour later, you get your third and last message from the RN, and she says, FYI, he's still going. Every time he coughs, more is coming out. He just went a bunch more. Can you come back to bedside? So before going upstairs, you order a unit of blood and a liter of LR bolus because you basically are attuned to that systolic blood pressure drop you commented on. And when he arrived to the bedside, the first thing you see on his bedside vital carts is a systolic blood pressure of 70 and his heart rate is 72. And that's this.
Yep, definitely concerning. This is looking more like kind of melena plus maybe hematochezia, depending on if it's really kind of like, ascending colon or very late, like the jejunum, something like that, It's not bright red, of course, but there's definitely some consistency here that's changed and it looks, more melanotic. We're at the point now where, I mean, I would say I'll just say that he's in shock. I'm guessing, we don't have any data to suggest end organ damage yet, but I'm guessing that that's what's going on here. I think that no matter what GI thinks, I think he needs like angiography, because I think I have enough of a concern for lower that it's worth ruling out. My concern is still highest for upper, but that's a test that I think would exonerate probably what's going on in the lower, right? Because if he's coughing and he's bleeding when he coughs or stuff's coming out when he coughs, it would be hard to say that it's going to be something subtle. So that would sort of be like a rule out while I'm talking to GI. Hopefully that's like something you can get done quickly. It can be complicated by creatinine and things, sometimes, if I don't know what his renal function is, but I'd say that in general, probably it's worth doing that while we talk to GI. I think that they're probably going to rescope him, is my guess, but you're not going to do a colonoscopy like this, right? You're going to this is an IR problem if you do think that they're bleeding below the duodenum. So, um, is he on beta block? Why is his heart rate so low? Is he on beta blockers? Does he have
Yeah.
salmonella? What's going on here?
Just he have salmonella. Yeah, he's not on beta blockers. What do you think about that?
Well, it's just odd for someone to, not just have a low blood pressure, but to have it develop so quickly, over the course of less than a day and not have any tachycardic response to that. It's odd. And beta blockers would probably explain it. Like I think that would be enough. But the fact that he's not on them, is certainly odd. I'm gonna have to
Yeah, love
marinate
it.
on that
Love it.
number, or
We'll
on
come back to
why.
that.
Yeah, I don't know that I have a great. I mean, salmonella is the classic of like, right, the paradoxical bradycardia, but I don't hear any risk factors for that or a presentation on a script that's significant, consistent with that. I do, if someone has like that degree of discrepancy, I'll get a EKG just to make sure that they don't have like heart block or something, right? Just like a just bradycardia differential and because it's kind of a relative bradycardia, even though it's not necessarily bradycardic by strict definition, right? So an EKG, but I think, regardless of it, he needs blood, he needs fluids, and he needs probably to rule out something lower and have GI take a look upper if they think he's stable enough.
I love
We need
it.
to get him stable. He's probably going to the MICU unless he has some miraculous improvement in the next 2 hours. He
He's
certainly would
definitely
at my institution.
he's definitely going to the MICU. I did all the things you did. Paged ICU for emergency triage request, paged GI for an emergent update, despite all of your messages to them the rest of the day. The ICU arrives quickly, and GI doesn't get back to you because they're of course like busy still scoping folks, and they're crazy busy. And after the fluid is pressure bagged and half a unit of the blood you ordered is given, the systolics thankfully come up to the 90s. Once the second unit of blood is hanging, we sent him to the CT scanner en route to the ICU. And he had active contrast extravasation within the distal transverse colon in the setting of diverticulosis. GI did perform a bedside EGD for a potential unstable upper GI bleeding once he went to the ICU, and they did not see any bleeding on the upper scope. They also did a bedside flex sig and just found copious blood, of course, confounding kind of their assessment. Did visualize the multiple diverticuli that the CT scan saw, and they didn't see any active bleeding. But overall, there was a suspicion for a diverticular bleed as the etiology of this decompensation. So I'll pass it to you. I have a couple reflections, but curious what stuck with you the most.
I mean, it's a great case of like recency bias, and recency bias is within the same case, within the same patient, right? And sort of like a parsimonious explanation here didn't necessarily explain it, right? Um, he's, if you remove the entire upper GI bleed history, right? If you just have an 80-year-old who has recently started on DAPT and has hematochezia, like, I mean, diverticular bleed is going to be very, very high on that differential regardless, right? So, um, I think that that's probably, I mean, probably the biggest reflection here is just, right, like the fact that once someone is not behaving the way you expect them to behave, then to expand your differential. I think, right? Because it's certain, I mean, they did scope him a third time. It wasn't unreasonable, but I think had you, not considered other things, maybe this person wouldn't have gotten a CTA. They would have just gotten like a CT, right? You could think about that as something that could happen. But yeah, hard to, I think I mean, it's a good case. Did he have it wasn't diverticulitis. It was just a diverticular bleed or, yeah,
Yeah, yeah. And I never
that's
answered your
tricky,
question.
right?
That
Because there's no like symptoms. And that's, I think, what like I think of like why does someone bleed? I think of like colitis, diverticulitis, like, proctitis, right? I think of like all these itises. But this is the one where profound bleed often, right? Because you have like the actual arterial supply open, but no necessarily like abdominal symptoms. So yeah, it actually behaved kind of the way it would.
Yeah, I love it. Uh, he had no leukocytosis, no abdominal pain, tenderness, kind of no itis as you mentioned. Yeah, I have a couple of reflections on this case. Since it's really like image driven, I just wanted to talk about melena really quickly. And these are kind of tips I feel like I've just kind of picked up along the way and not necessarily from like a GI doctor. So please, listeners, like fact check me on any of this and leave us a comment on Spotify or email us if you feel like this is not completely accurate information. But yeah, the differentiation of kind of blood in the stool, melena should really be like black tarry, like Mike said, like you can't see through it and it's like jet black. When you go and look at these photos, there are clots and it is certainly very dark, which is exactly how the nurses describe it. But in my experience, dark clots often get overcalled as melena by RNs. Like you go to the bedside and on the way, you're getting messages kind of saying, hey, patient has melena. And then you go look. And the stool is very dark, but it's not this like jet black character that you're taught to look for. And Mike already did fantastic teaching on if you do see jet black stool, where it can come from. It doesn't include just kind of the stomach and duodenum. It's also distal to the ligament of trite, small bowel, right colon, and then also like upper beyond that, like epistaxis, like he mentioned. And something I found really briefly on kind of characterizing the melena, apparently, the more liquidy it is, the higher the suspicion it is that it's representing significant active bleeding. Whereas if it's really more dry, kind of like it looks like a well-formed stool, but it's jet black, usually that represents a less active bleed or old bleed. So that would have been a little bit more reassuring that what we were seeing at this time was in line with what GI was saying initially. Like, hey, we expect some like clots. Although they did say clots in this case, but if it were like, if the stools were very formed in black, that would have been more reassuring that actually, okay, this is like small bleed or this is old bleed in this case. Whereas in the photos, it was a little bit more like liquidy, like gelatinous sort of clots. And if you look, the other tip I kind of have, if you look at the towel, actually, it really brings out kind of the redness in it. Like if you look at the little streaks, it does look, at least in the first photo, more red than black. Whereas in the other photos, it starts to look a little bit darker for whatever reason. So, 2 points on false reassurance and kind of the analysis of GI bleed. Mike actually pointed out the absence of the kind of profound tachycardic response. I've seen this a couple times actually, where I had a patient come in with hematemesis, and the initial heart rate was very unimpressive. Yet an hour later, they were crashing in the ICU. This patient was doing the exact same thing. There was like an absence of the expected tachycardic response. So if you see that, that should not reassure you that the patient is not having an active bleed. And Mike already pointed out one important reason that can happen. And that earlier patient I just described, he was on a beta blocker. So many people are on beta blockers. So you want to look for that, as Mike said. But if you're not on a beta blocker, you just think of like chronotropic incompetence. Like some people just like need pacemakers past a certain age because their sinus node just doesn't conduct as fast or doesn't generate beats as fast as it should. Basically, they just have kind of like a sleepy conduction system. So you can kind of explain it away with that. So don't be reassured by absence of tachycardia. The other thing is, I didn't give you like a CBC other than the morning CBC of that case, but I think we can probably make an educated guess that this patient probably started bleeding somewhere before the blood work was drawn that morning because he was so hypoactive. Like when I saw him, he was so much sleepier, and the patient said, or the family said, he looked more pale. I bet you that he started bleeding like in the middle of the night and he was just like holding on to it a little bit. And when I saw him, he was already starting to kind of like feel that from a perfusion standpoint. So, all this to say, I think the kind of better way to triage this is kind of use your eyes, like just believe what you're seeing. So blood pressure drop, Mike was already attuned to this. If you see a decrease in the nadir, that's real, even if it's not like true hypotension, like it's not less than 90. This guy had a 30 systolic drop. That's real. So believe your eyes there. And then just like looking at the patient, if he's kind of not perfusing his brain as well as before, could be a little bit hypoactive as he was in this case. And that was a huge teaching point for me. I'd never kind of seen that before. And then, of course, you're going to the bedside and using your eyes to see what's coming out of the patient. So he was, passing clots too. So if you put all of that together, that was kind of, I think, what made us collectively worried about this patient throughout the day. I'll leave it there. I think there's a lot to be said about GI bleeds. I'm very curious what the listeners have to say about this case. Yeah, kind of a tough one to manage on the floor, right, Mike? I feel like you've probably done this a couple times too. It's very challenging because you're kind of just like sitting around looking at your watch, waiting for more poop to come out, waiting for vital signs to change, waiting for GI.
Yes, these are challenging for all those reasons because you don't need a lot of time. You don't need days, but it is uncomfortable to kind of have a couple hours go by and you don't really have like a you don't have an answer, you don't have a management plan, and there's sometimes a pressure just to act and do something, right? And sometimes I think we will, if we make a plan, if we make a contingency plan of kind of if-then statements, and then things go well by following those if-then statements, right? It doesn't necessarily mean that if you weren't concerned at the first time the nurse let you know about something, right? But you made an if-then, you followed your contingency plan, that's not a failure of judgment, right? That's just you created a system and you worked through it. So I don't think there's anything that would have done differently after the first. Also remember, and I don't want this to come out in any way sounding like I'm insulting anyone here, because it's not in any way what I mean to do. But remember that sort of like nurses are much more focused on sensitivity, right? And physicians are much more focused on specificity, right? Nurses are really trying hard not to miss anything. They want to bring things to your attention. And so, you know, when they call you to the bedside for something, it doesn't necessarily mean that they think that this person needs something necessarily, right? Sometimes it's for reassurance or for explanation. Sometimes it's to explain things to the patient or the family, right? So that's a different type of test. People are tests too, right? People are using their own judgment and pretest probability. And I think that nursing training in school is much more focused on, in some ways, at least inpatient, bringing attention to things that may be otherwise missed. I mean, remember, you have to go from normal to abnormal, you have to go through low normal or higher, upper limits of normal or lower limits of normal, right? So like, if you're getting blood pressures on everyone every 2 4 hours, right? Like at some point you're gonna catch something that's like down, but not quite as down as you'd expect. And so trajectory and acceleration matter more than absolute values. And I find that nurses are better at picking that up than doctors sometimes, because they're just at the bedside often and they're getting slices in time on a much more granular basis. So if they're worried, doesn't necessarily mean you have to be worried, but it does mean that you have to provide reassurance and give them an if-then plan. I think that's important.
Words of wisdom. Thanks for tackling the case, Mike. Hope we all have a good week.
Thanks, Andrew, and thanks everyone for listening. This has been Diagnostic Atypia with Doctors Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us at dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.